I'm Dr. Sabrina Bra. Welcome to the Better Breathing Institute webinar series. The platform provides education and accredited information on insights to do with respiratory muscle training. And we support healthcare professionals, athletes, patients, and really anyone looking to deepen their understanding of breathing, while fostering a global community with a shared interest in respiratory health. Today's webinar is really exciting. We will be exploring the growing role of innovative rehabilitation strategies utilised to optimise respiratory healthcare in paediatrics, for example, inspiratory muscle training. It's going to be led by Claire Chadwick, who is a specialist physiotherapist at St George's NHS Hospital in London. And the webinar will examine the current evidence base underpinning inspiratory muscle training in the paediatric population. We will be guided through the science, along with examples demonstrating the clinical application of breathing training across a range of paediatric conditions, discussing the potential that IMT has to improve patient outcomes and how you can introduce it into your day-to-day practice. I would like to give a special thanks to Claire, who has not been very well this week and has also been suffering with laryngitis. So she's going to do her best during today's presentation, but we're very grateful for your time. So without further ado, I'd like to hand over to Claire, and there'll be an opportunity for questions at the end of the webinar. Thank you.
Thanks, Sabrina. So I'll just start sharing and then tell you a little bit about myself. Can you see that?
Yes.
And you can't see the notes page?
No.
No. So welcome everyone, and thank you, Sabrina, for having me on today. As you can hear, well, maybe I don't always sound like this, so hopefully my voice makes it through the next hour, and hopefully you'll come away with some tips and practical advice around respiratory muscle training. So yeah, I haven't been very well, but hopefully I'm somewhat prepared for today. So just a little bit about me. I qualified about 19 years ago in South Africa. I've always done cardiorespiratory physiotherapy in some form. I've been in the UK for the last 14 years. And that's all sort of been dedicated to pediatric respiratory physiotherapy in various forms, whether it's been CF or bronchiectasis, HDU, and PICU. For the last sort of 10 years, I've specialized mostly in asthma and breathing pattern disorders and complex breathlessness, including sort of upper airway, ILO, and cough. I've worked at various different teaching hospitals within sort of South Africa and the UK. And I've set up the asthma and breathing pattern services within King's College Hospital in London, and now at St George's Hospital in London as well. So currently I'm the clinical lead at St George's Hospital. I'm also doing my advanced clinical practice MSc. And I also work at the Institute of Sports, Exercise and Health, where we treat and see a lot of elite athletes anywhere from the age of 12 to help support them with any respiratory conditions. Obviously, most of that is breathing pattern disorder and ILO. So I guess I've always had, probably from my training in South Africa, I've never really accepted this, we don't use this or we don't do this. And that's definitely something that I think in South Africa and other sort of countries we're much better at doing. When I came to the UK, it's much more protocol driven and guideline driven. So I've always just been this type of person wanting to ask why. And I think that's always just led me down this path of looking at different things, and probably led me down the path of, looking into respiratory muscle training and how that could support my patients. And so really, when I was sort of looking into this about sort of 9-10 years ago, I just really felt that it could be beneficial to the type of patients that I saw, and kind of haven't stopped sort of bugging Duncan Kerr since then. So that's just a little bit about me. So hopefully today you'll have understanding. I'm not going to go into, what respiratory muscle training is hugely. There's many other webinars that Sabrina's already put on with lots of other fabulous speakers. So please do go watch those. But we're going to think about, what respiratory muscle training is, what that means for children and how they differ from adults. We're going to look at the sort of the evidence around that. We'll look at the clinical sort of indications for respiratory muscle training and some devices and age-appropriate ideas. We'll think about safe and appropriate programs, and then also thinking about how do we monitor to see if what we're doing is helping. So just quickly, briefly, respiratory muscle training is a targeted exercise intervention that aims to improve the strength and or endurance of muscles of inspiration, primarily the diaphragm and external intercostals, and muscles of expiration. We have two different types. We have inspiratory muscles and expiratory muscles training. Obviously, one's focusing on the inspiratory muscle and the other's expiratory. And our training targets either to increase the strength of the muscles or to increase endurance. We know that the diaphragm has equal proportions of slow and fast twitch muscle fibers, but we do need to think about this is slightly different in children. The diaphragm has a lower proportion of type 1 muscle fibers or slow twitch muscle fibers, and therefore children or young people are will fatigue quicker than adults. So that's just something for you to think about when we are thinking about strengthening the diaphragm. The intercostals also have a high proportion of high twitch fibers, and this type 1 fibers starts to rise or increase as the child gets older as well. So there are just some key fundamental differences between adults and children. So what are we aiming to do with respiratory muscle training? We're obviously aiming to increase the fiber hypertrophy. We want to increase those muscles, fibers. We want to strengthen those, inspiratory and expiratory muscles. We want to increase that neuromuscular efficiency, so how the muscles work. So we want to increase that coordination, specifically of those breathing muscles. I specifically use it to help improve breathing pattern. It can be a really nice feedback tool for breathing retraining. It also has been shown to reduce perceived effort, so it helps with complex breathlessness. And then it helps to improve the biomechanical efficiency. So it helps to strengthen expiratory muscles and improve cough, and also can help mobilize the joints. So any movement can help move through the joint and help maintain and mobilize those joints as well. Sorry, I will be sipping water throughout this. So children are not just small adults. And if you've ever spoken to a pediatric therapist, you would have heard this before. But why? So there's quite a few fundamental differences between children and adults, and I'm not going to speak about all of them, but in an infant, the thorax is more cylindrical. Those ribs are much softer and cartilaginous. The angle of the rib in the sternum is more horizontal, and that also means that the diaphragm is sort of flattened as well, and those intercostals are poorly developed. In adults, we have a more elliptical rib cage. Those ribs are calcified and more rigid, and the angle of the sternum is more oblique, and it's more of a bucket handle. So it's at a better position for that diaphragm to move efficiently throughout range. And we also know the intercostals are more developed. The diaphragm, and I think I've already alluded to, is more horizontal. Relatively, obviously, it's less muscle mass. It's not as developed, and there's a low content of those high endurance muscle fibers, as I alluded to in the last slide, and therefore children are more vulnerable to fatigue. while the adults have a much higher muscle mass, higher content for endurance, so they can carry on for a lot longer, and they are able to, they're much more fatigue resistant. And these diaphragms are quite nice to see the differences between children and adults. As you can see, I'm not sure if you can see my cursor, but you can see the differences between the child and the adult, and the differences of how sort of flat the diaphragm is versus in the adult. We see sort of changes within the skeletal, within the ribcage and the skeleton, and this sort of starts as the chest wall starts to stiffen, those intercostal muscles strengthen and start pulling on those ribs. Also, there's big changes in various different age groups. So between age 5 and 8, we see big improvements or big increase in alveoli and airway size. And between sort of ages 8 and 12, we have increasing efficiency of the respiratory system. And then as we get older, essentially we are getting to a more adult respiratory system. So if you look at some of the research, often they will say at the age of 15 years, that's when our skeleton or our respiratory system becomes sort of that adult maturity. Well, not the skeleton, sorry, more of the respiratory system becomes of adult maturity. But does it really? We know that children vary so much. They vary a lot now within sort of when they're going through puberty. So really, yes, at 15 is a good age to think that we are reaching maturity, but that will carry on much later into later life as well. So this will steadily increase. This sort of diagram is showing sort of how the respiratory system or the rib cage changes. So we can see there's not much change, and it increases steadily until sort of reaching around the age of 15, sort of to about around the age of sort of 100% maturity. But again, I think there's lots of things to think about that are going to influence that. In children, airways are much narrower. They are more funnel shaped. The larynx is more funnel shaped and narrower. The bronchial walls are much more cartilaginous and floppy. So these are just things to think about when we're thinking about how we go about doing our muscle training, respiratory muscle training, especially if we're thinking about flows and thinking about how maybe different airway principles like the Bernoulli might affect. So we just need to think about doing things a little bit slower. Otherwise, we're probably going to lead to a little bit of collapse of those airways. So it's just considerations to have as a child gets older. So things that might influence why these changes start to occur. Obviously, we have things like children start sort of walking and crawling, or crawling and then walking, and that's when a lot of changes happen to our skeletal development. Then as we get a little bit older, into sort of 5 years of age, kids are a lot more active, they're running around, so that cardiorespiratory need or that is much higher, so they are doing a lot more exercise. So cardiovascularly and cardiorespiratory, they need more air and they need more capacity. And then as we get into adolescence, there's this big change when it comes to the growth hormone and estrogen and testosterone, all of which help to sort of start maturate the skeletal system and the respiratory system for our adolescents. So if we're thinking about skeletal maturity, skeletal maturity is usually reached around 14 to 16 years in girls and a little bit later in boys, up to 18. The final fusion of some bones continuing into those early 20s, and that's why my question is, well, are they really completely respiratory mature at the age of 15. During puberty, there's a lot of changes. As I've said, there's a lot more sex hormones, and that's when those growth plates start to close. And those ages are corresponding kind of with the end of those growth spurts. But as I said, some things like the clavicle and the spine fuse much later on, and that can happen up until sort of 20s and even sometimes later. So really, skeletal maturity is not the same as chronological age, and there's many things that are impacting or influence skeletal maturity. Generally, skeletal maturity is reached slightly later in boys than in girls. So respiratory maturity undergoes a big development alongside the skeletal development. Generally, there's a lot of changes within that early childhood, with alveolar maturation happening around about 8 years. But again, we need to be thinking slightly older when we're thinking about respiratory maturation. There's also a lot of different physiological differences between adults and children. Haven't really gone into that because they're less relevant when it comes to respiratory muscle training. So I guess this is just going over a little bit of what I said, but the rib cage is more horizontal, the diaphragm is less in a mechanical advantage position, and the chest wall is highly compliant, so there's higher risk of fatigue. When we think about training in children, children do have a similar neuromuscular ability to train as adults. Strength gains occur within similar 4 to 6 weeks, and children might even show faster sort of neuroplasticity as long as we are keeping it fun and making sure they're doing that consistently. Psychological factors in kids, motivation, parental involvement. We really need to engage children. Also, understanding the disease and understanding why they're doing things is really important, and that will obviously depend on their cognitive age and how, their ability to stand, or if there's any other sort of learning needs for that child. Normative values, I'm going to go a little bit further into this, and there's a really nice paper from Verma that we'll speak about a little bit later, but they're not sort of, normative values obviously increase as their age and height and sex develops. No, age and height, sorry, and it's also obviously dependent on their sex. Assessment challenges, obviously in children, it can be a little bit harder to assess, but we start spirometry as early as sort of 4 or 5 years old in kids, and the ATS and ERS are suggesting that with good coaching, you can even start doing your MIPS and MEPS around 6 years old. So it also shows, so if you look at the evidence, it shows that respiratory muscle training appears to be safe in children with chronic conditions, and there's overloading risk is lower than in adults due to a smaller absolute load. So I guess what we mean by that is we're probably starting off with lower loads, so we are less risk of adverse events as well. So I guess this is where this has all come from, sorry. And I certainly remember when I trained, which was a while ago, is that it was said that strength training in children isn't a good thing, that strength training would affect growth, it could cause damage to the growth plates, they're going to injure. So really, I think that's probably why a lot of people have stood away or stayed away from respiratory muscle training. So I thought really talking about this is really important, and debunking the myths. The current scientific consensus is that properly supervised resistance training is safe for children and adolescents and does not damage growth plates or impair any bone development. So strength training does not damage the growth plate or stunt the growth. children cannot, so some of the myths, children cannot grow strength because they lack sufficient testosterone. That sometimes you might have heard that. And another myth is weight training is too dangerous for children and can cause injury. So those are, I guess, the big myths that we have been told, and certainly throughout my training. But actually, if we look at the evidence, there's no peer-reviewed study that demonstrates any growth plate damage. And growth plates are no more vulnerable to resistance training, to resistance exercise than any other sport. Pre-pubertal children achieve significant strength gains through neural adaptations alone and not just hypertrophy. So actually just going through the motion and doing that exercise can be really useful to improve strength or strength of that muscle. And injury rates in youth resistant training is lower than in other things like football and gymnastics and recreational sports. So really the risk is of loading a muscle is really low. And so I think we can take that across to respiratory muscle training. We'll talk a little bit about the benefit strength training, and hopefully we can, take some of this again over to respiratory muscle training. Muscular strength and endurance, we can see gains, as I've alluded to. Actually, strength training stimulates osteogenesis, so that helps with stronger bones. Strength training also supports body composition, so reduces fat mass and increases lean mass. I appreciate not all of these things we can probably take over to respiratory muscle training, but it is important, I guess, to note. Mental health is affected by strength training, improves self-esteem and reduced anxiety. So, and then also injury prevention reduces sports injuries by up to 50%. So when it comes to strength training, so safe practice guidelines is ideally should be qualified supervision at all times. I don't think that's the same for inspiratory muscle training, but we can all discuss about that later. For those of you who are using it regularly, start with body weight first and assess the technique. And I would probably agree with inspiratory muscle training. You really want to start off light and make sure you assess the technique, and then start adding a load after that. You can start strength training between 7 and 8 years. Progressive overload or gradual load increase is what is suggested. Working through full range of motion with proper form and rest and recovery is obviously really important, and making it fun and varied, and making sure the child is engaged and actually is ready to do that whatever exercise you're giving them. So I guess a little bit about what is strength training, because some of the things that I'm going to discuss, people are probably going to argue, well, that's not respiratory muscle training. But so this is why this is important. Strength training is a form of physical exercise that uses resistance to induce muscular contraction, building strength, aerobic endurance, and skeletal muscle size. It encompasses multiple distinct modalities, each have their own benefits. So we've got different types of strength training: isometric, plyometric, functional, isotonic, and eccentric and isokinetic. I'm not going to go into all of them. I'm going to save my voice so you can read through that. But the things that I think that we can use within respiratory muscle training are the first, the following, sorry. So isokinetic training is a movement that occurs at a constant preset speed or resistance that automatically matches the force applied throughout the range. So these are kind of your cybics, your dynamometers, your biodex machines. Normally they're used for clinical research and settings, but we're seeing more and more of these in the gym as well now. But actually spoke to Sabrina, and POWERbreathe, the K2, probably does something similar, where it just titrates the resistance given throughout the breath. So it is something we can think about. What isokinetic training does, it helps muscle loading throughout that range. It helps with testing, but also reduces risk, injury risk versus free weights. So obviously we're not using free weights for respiratory muscle training, but it's just something to think about. versus isotonic training, the muscle contracts through the range of motion, includes concentric shortening, and eccentric lengthening. So these are things like your squats, your deadlifts, bicep curls. But when it comes to respiratory muscle training, this is probably your IMT or your EMT devices. And that helps to increase muscle mass and strength, improves bone density, and also boosts metabolic rate. So functional training is multi-joint movements across multiple planes that mimic daily activities of daily life. So that might be kettlebell swings, carried loads, battle ropes, and when it comes to me and my colleagues, diaphragmatic breathing in different positions, and also then thinking about IMT or EMT during activity or sports. And functional training helps to improve coordination and balance, helps to transfer movement into daily function, and maintains good joint mobility. So hopefully when I talk a little bit later about some of the sort of modalities I might think about using in children, you'll be able to see that actually maybe some of these things are giving benefit, even though they might not have a specific or measurable load to it. So loaded versus unloaded training, and I guess again this is coming into my when we speak about things like incentive spirometry, which I know there's a lot of discussion, is that respiratory muscle training or not, but actually we have loaded respiratory, we have loaded obviously training versus unloaded training. So there's different examples of that, resistance machine or sort of, you know, I've put in the incentive spirometry or breathing retraining. There are benefits of unloaded exercises. It helps to maintain joint mobility and neuromuscular pathways and enhances early rehabilitation before you can start loading, and it's well tolerated. So I think there are benefits to doing these sort of things, especially within the children. So can a muscle get stronger without external resistance? So yes, we can use our muscles without it loading and still see the benefits. Unloaded high repetition movements produces neurological and modest adaptations, but obviously it cannot match match the strength and hypertrophy gains when you are progressively loading or adding resistance to that training. So how does it happen? We get changes from neuromuscular adaptation. So early strength gains are gained even with low or no load, and that's normally through sort of motor recruitment, sort of firing of those muscle fibers and coordination. Then we get endurance versus strength continuum, so high repetitions with no external load helps to train the slow twitch fibers for muscular endurance. So that's probably things that we're thinking about that can be quite helpful potentially for the diaphragm. And then the progressive overload ceiling, unloaded sort of range of motion exercises hits an adaptation ceiling rapidly, and one movement is easy. The stimulus, if that movement becomes easy, then the stimulus is insufficient. So this is just saying that gravity can be a resistance, but you're not going to be able to sort of build those maximum strength long term. So let's look at the evidence when it comes to respiratory muscle training in children. So just did a quick search, and I'm sure a lot of you have already done it. If we look at respiratory muscle training in pediatrics, we get about 6 good quality reviews. And if we look at the randomized control trial, well, really, there's actually only about 18. And if we compare that to what we see in adults, you can see there's a huge difference between the studies that we're getting in peds and in adults. So what we are seeing in pediatrics, there's a few studies in CP, asthma, CF, and neuromuscular disease. But yeah, there's just not a lot of evidence out there. So what does the evidence say? So respiratory muscle training in children and adults. So not or even some of the evidence isn't even pediatric specific, but really when it comes to neuromuscular disease, there might respiratory muscle training may improve lung capacity and respiratory muscle strength in some neuromuscular diseases. This paper, Inspiratory Muscle Rehabilitation Training in Paediatrics, it's a decent read, so go away and read it. It talks about sort of various different areas. So, for example, it discusses performance, and it looks at performance in swimmers, and it says sort of in the high level, very competitive swimmers, we don't see much change or improvement, but actually in your amateur swimmers or those who are training a little bit less, actually they might benefit a little bit more from IMT, whereas runners actually performance did improve after a training of inspiratory muscle training. And other things that improved was ratings of perceived exertion and dyspnea were lower though in those swimmers. There were improvements in forced vital capacity and forced expiratory volumes in some of them as well. That paper also speaks about neuromuscular disorders, and it says, however, there's a lack of evidence. It does feel that there can be some benefit of respiratory muscle training. And then when it came to asthma, it said that there was improvement in asthma symptom scores, so your ACT scores, asthma control tests, and obviously there was improvements in their MIP and MAP, which might be not as relevant to asthmatics because I haven't actually looked at the evidence around reduced MIPs and MEPs in asthmatics, but not to say there isn't, but there is increase in overall respiratory muscle function and perception of symptoms. So I think that's quite helpful to know, and similar to adults. So effective inspiratory muscle training in children with asthmatics. So this is similar to the last paper, but this was a big review, and there was significant improvements in the MIPs and MEPs. Again, whether or not how helpful that is for asthmatics, it might be, and might contribute to why they're not feeling maybe as breathless, but there is improvement in forced vital capacity and force and other sort of lung function results as well as the ACTs. When it comes to chronic heart failure, I think there's a little bit more evidence in that, and it shows that IMT could improve pulmonary function and exercise tolerance and quality of life. So I think, and obviously perceived dyspnea or some improves symptoms. So I think it is something that we could be thinking about or should be thinking about in that cohort as well. In CF, a systematic review and meta-analysis stated that there's not a lot of evidence and the evidence is low, but it might be helpful and probably need some more research into that. So really, as you can see, I'm not going to talk about all of them, but as you can see, the research is very limited when it comes to IMT and pediatrics in general. Sorry, just going back. And if we looked at expiratory muscle training in children, well, that's even more rubbish, and there's even less. So there's very few good quality studies when it comes to expiratory muscle training, and really, well, that in adults as well, but these are kind of the only two that I can come up with. One is in CF, and one is in asthma. And you can also go away and read those, but there's just huge gap in the evidence around EMT. So Sabrina asked me to talk about resistance and respiratory muscle training in neuromuscular disease, because we have seen a couple of patients together, or I've also been using it on a few patients alongside our LTV team. Caveat, I'm not a neuromuscular specialist, but I have had many years of use, as I've told you, working with patients with neuromuscular experience working with neuromuscular disease patients with respiratory care, whether that's in PICU and PICU or complex respiratory. So I thought we'd talk about it, but I'm not a specialist in this field. So what does it say? Resistance training or strength training? Again, I think we need to take it back, because our respiratory muscle training is a resistance or strength training. So if you look at in Duchenne's muscle dystrophy, it says that the moderate resistance is safe, but we probably need to think about staying away from eccentric loading, which respiratory muscle training is not. In SMA, resistance training has been shown to improve muscle strength and function, and they suggest that doing this along sort of gene therapy is helpful. In other things like CMT, resistance training has helped to improve strength and quality of life, and similarly in other neuromuscular diseases. So I guess the key principles to take away from, sorry, that was just overall strength training. I guess the key principles to take away around neuromuscular disease and resistance training is avoid overwork or weakness. So just thinking about training, and sort of, this is when I looked at the research that said sort of train at 67% of 1 rep max. I wouldn't even suggest doing that, but that's what some of the papers say. But we'll look a little bit more about it. Think about post-exercise fatigue, avoid eccentric contraction or loading, thinking about age-appropriate goals. So what are you trying to achieve by doing this, and how are you going to monitor this? Thinking about gene therapy interactions, so working alongside that neurological team, is it going to affect it in any way? And thinking about maybe fewer training sessions that you might do in a child with neuromuscular disease. So IMT and pediatric neuromuscular disease, there's not much out there, as I've said. There's a paper by Topin which talks about IMT, and it improved obviously their MIP and reduced dyspnea in boys with Duchenne's, and there's a couple other studies showing that it might have slowed respiratory decline, and then there's a Cochrane review as well that shows it might prevent restrictive lung disease progression, and reduces respiratory hospitalization. So I think those are all things that can be helpful for this cohort who we know go into hospital very frequently. So respiratory muscle protocols for pediatric clinical, for pediatrics, a clinical guidance for neuromuscular disease, thinking about much lower thresholds. So I mean, I would probably even start much lower than 30%, progress very slowly, thinking about the frequency, how often are you going to do it? So probably less sets, and maybe staying to, sorry, where am I? EMT, again, I couldn't find much information about this, but EMT might help with secretion clearance as well. A PEP device can be giving resistance in EMT, so that might help with secretion clearance. So thinking about how you might put that within the play sessions as well, and different things you might want to monitor or would be monitoring in these cohort anyway. In the neuromuscular, you would be monitoring your MIPS and your MEPS and your lung functions and your peak off flows. So those are things you would be taking, and you could see if there's any improvement. The contraindications, I would say, are obviously normal contraindications, but I wouldn't do it in the active respiratory infections. And if they have anything else going on, which I know a lot of our children do with neuromuscular disease. These are just some other things to consider when it comes to neuromuscular disease, thinking about monitoring their strength relatively to their growth, and their bone health. We know that a lot of these kids are high risk of fracture, so just thinking about that when it comes to strengthening, thinking about scoliosis surveillance, and any pubertal changes that might be happening alongside that. Then thinking about their physiological engagement, the use of play-based sort of exercise for children as much as possible, thinking about how you can integrate that into the school system. Can you think about talking to the SENCOs, speaking to the PE staff, getting them involved as well? Obviously, family and carer training is essential. And also just being aware of the mental health of these kids. They've got a lot going on, and actually is adding another thing, just too much of a burden for them. So, is this something that actually is appropriate for them at that time? Then monitoring and safety, you use your normal monitoring tools, pediatric quality of life, and I'll speak about it a bit later. There's a specific neuromuscular module. Your 6-minute walk tests might differ from children without neuromuscular disease, and then obviously you're going to have your normal respiratory surveillance. So there's some of the studies done within neuromuscular disease. The study it says that respiratory muscle or inspiratory muscle training in children with neuromuscular disease appears to be safe and well tolerated, with significant improvement in respiratory muscle strength and cough efficiency. So I do think it is something that we need to be thinking about. The study talks about a combination of sort of functional IMT and functional sort of trunk control exercises, so either IMT or combination, and both were shown to be helpful. So again, I think there is some evidence, not huge sample sizes, but there is evidence coming out, and this is also just another one saying that it was helpful, but that was done via telemedicine. So what are normative values for children? I think if you are looking for normative values for children, this Verma paper is really helpful. And you can see it gives you different age groups and how it changes. But actually, as you get from 12 and older, you're looking at normal values and very similar to adult values as well. So if we're thinking about starting IMT, I think we're pretty safe to say that if we're starting resistance training from 12, well, we're looking at similar loads or strength, that we would from adults. So I think hopefully this will show you and make you feel a little bit more comfortable that we are seeing that kids and adolescents are pretty strong when it comes to their inspiratory and expiratory muscles. So we hopefully will give us some reassurance that it's safe to do. So indications for use, I guess what you need to say is what problem are you facing? Is your patient sitting in front of you, do they have poor cough? Are they complaining of increased dyspnea? Do they have a poor breathing pattern? Do they have poor rib mobility? Or is there something else that I haven't even put up here? And what is the patient goals? What are they hoping to achieve? And then are we thinking, well, can respiratory muscle support this? And could respiratory muscle training be done safely? I kind of feel like, as you can see, and I've always had this proof, evidence in therapies and pediatrics is just always so behind. So if the patient will benefit from it and we feel safe to do so, well, then I think we should be thinking about trying it. And does that patient, or would that patient benefit from it? Does it reduce their symptoms and does it improve their quality of life? Well, then I think it's something that's helpful for that young person. Where I'd like to see more research in pediatrics is things like CPAMs, although that's a very small cohort, or GORD as well. We're seeing a lot more patients with GORD, and we know PPIs are really, really bad, and some of our children are on PPIs long term. So if we could be supporting them with, non-pharmacological things like inspiratory muscle training, well, I think that's really important to get them off those medications as soon as we can. Hypermobility, we know our patients with hypermobility struggle a lot, number one with breathing pattern issues, but also with injuries and posture and balance. So, if we can increase or strengthen the inspiratory muscles or expiratory muscles, will that help support with their hypermobility? I don't know, but I think that's the interesting question, as well as POTS, because we know POTS and hypermobility and breathing pattern all go hand in hand. So just aware of time, and I said to say to Sabrina, I always talk much longer than I think I will. As I said, there's not much good evidence yet, but actually I think there's lots of indications very similar to adults. Just because the research isn't there yet doesn't mean we shouldn't be using it. Formally with devices, we could probably start as young as 5 years old, younger if you're using games. How I use it with breathing retraining, very low resistance, and that feedback is really helpful for patients to get that sort of good rib movement and diaphragm breathing. I use a lot in disproportionate breathlessness and dyspnea and ILO, and in athletes as a breathing warm-up. They warm up everything else, but our patients that are having a lot of breathing pattern issues or ILO, really using IMT as a warm-up can be really helpful. And then I've used it alongside with LTV physios for neuromuscular disease, and I've started using it more for POTS and hypermobility. Considerations: time, be practical. Children and families have a lot going on. Engagement, keep it short. Make it fun. Adherence drops in orphan adolescents, so just be aware of that. And that's quite normal. Monitor the SATs and BORG initially, and consider biomechanics and breathing pattern. Obviously, I'm a breathing pattern physio, so really how we're doing it is really important for getting for making sure we are strengthening the right muscles. And I've also used it before in weaning and ventilation on PICU and in GBS patients as well. So I think there's lots of ways we can be using it. So how do we make it fun? Well, expiratory training is much easier. Blow painting, there's loads of different things, and that's why I really wanted to bring in, can you strengthen muscles without a huge resistance load? I mean, a lot of these things are going to give resistance, balloons, all these games will give a little bit resistance, but actually going through those motions can be helpful for the neuroplasticity, so you are going to get benefits. So these are just a few ideas that you could go away and try. When it comes to inspiratory muscle, it's a little bit more challenging to make it easier. In center spirometer, again, there's always this big controversy. Is it IMT? Well, if you can use it functionally for breathing retraining or to get a diaphragm engagement, getting the diaphragm moving, then yes, I feel like it can be used as an IMT device. Obviously, there's lots of other things, making fun sounds, swimming, therabands, and there's lots of other games and things out there. Using band, doing more functional things can be quite helpful as well. So getting creative and making it fun. Obstacle courses, all the fun things that we get to do in pediatrics. So prescription and monitoring, IMT, most studies suggest starting at 30% of your PI max. I really would suggest, and they suggest sort of 10 to 20 minutes. 20 minutes is really long. I would never go for that. I would suggest starting at a much lower load, go with what feels right for that patient, what was the light resistance where you can get good technique. This might be only 10 to 20% or even lower, but really we could be using it similar to adults, 3 sets of 10 reps with a rest in between, aiming for 5 times a week. EMT, I couldn't really find any good evidence for how you should start doing that. So if anyone has any suggestions, please do, or any papers, please do share. Then this is quite, I saw this on the breather, breather is an inspiratory and expiratory trainer combined, and they have some nice information for kids on their website. So Sabrina, I think you need to have some dedicated pediatric space we need to work on, but really, we can start at 5 years as long as the patient can follow instructions, or you do your games, which you might not be able to follow instructions. Can they have a good seal of their mouthpiece? Can they participate in short-term sessions, and can they sit still in order to do the training? When I wouldn't use it personally is pectus excavatum, and that's just because IMT, if you're sucking in, I just wouldn't want to repeatedly suck in that, so I would probably stay away from that. Pure symptom recognition, especially in asthma or neurodiversity, and I see a lot of kids with breathing pattern and neurodiversity, so I would probably think about or cautiously going, well, if with asthma, I'd probably stay away from it altogether. With neurodiversity, I would probably just think before I start that. Obviously, if they're poor compliance with all the other medication, I wouldn't add another thing in. If they're not taking the medication well, then or doing their sort of airway clearance, I wouldn't add any other adjuncts. And obviously all your other listed contraindications, which I'm not going to discuss. These are already discussed in other webinars. So how do we know it's working? Well, there's various different outcome measures like PED-SQAL. There's disease condition specific, so asthma, CF, neuromuscular. There's RCADS, which is anxiety and depression. There's an asthma control test and the childhood asthma control test. So there's various different appropriate screening questionnaires or symptom and other appropriate symptom questionnaires that you might want to be using in adults. They use things like a SEDQ, D12, and things like that. They're not validated in children. Other things are monitoring, obviously, is your spirometry, your MIPS, your MEPS, your S-index, and other exercise tests, and just reassessing their breathing pattern. So my key takeaways. Sorry, Sabrina, my voice is at least held out. But my key takeaways is always ask why or why not. Why are we not doing this, or why can't we do it? Let's use some common sense, I guess I would say. Don't wait for the evidence. Let's create the evidence. Don't be afraid to try something a little outside the box, because that's how we, improve things. Stay safe, monitor, review, and make therapy fun. I have lots of references here, but yeah, thank you. Sorry, that was much longer than anticipated.
You did it. Your voice lasted. Thank you, Claire. I think that's opened, as always, a can of worms. And one of the biggest takeaways is obviously there is a significant gap in our evidence base that's specific to children. However, as you alluded to with things like hypermobility, even POTS, GORD, we have got emerging evidence in adults. And can that be transferred with consideration to the physiological differences in children? Perhaps the answer is yes. Somebody has written a question, and feel free to type any questions that you may have for Claire. And I think it's sort of been answered, but they've put what specific criteria. I think it touches on a lot of points. Essentially, they've put what specific criteria for asthmatic children should be considered for referral for IMT. Now, you later on in your talk talked about what we should be doing to start, and some of it is what you've just touched on in your last slide. Don't wait. The evidence is lacking. Don't fear. And then you talked about asthma maybe not being something you would consider, whereas in adults, obviously, there's lots of evidence supporting it. So do you have anything specific about asthma and IMT that you wanted to say?
I would say, and I don't know, I don't know if this is a doctor who's saying refer. I would always suggest referring for a physio review, and then the physio can decide. You could make a suggestion, you could speak to that physio, but I guess I would never just refer for one intervention because it might not be not the right thing for that child, and then parents get this in their head that they need to have that done. So I would say, can I have a physio review with, potential for some respiratory muscle training or breathing pattern retraining, or because they have, poor symptom recognition, or, I probably wouldn't do IMT for that. But I think I don't have any specific, I guess, for my service, when it comes to difficult asthma patients, they all get physiotherapy, so they're all getting screened, and they will be given whatever they need. And then I just get reviews for ILO, breathing pattern, cough, and overall, and then I make the decision as the therapist if I think this is going to be helpful or not. So I'm not sure that's answered the question. I guess in children, when they have asthma, we are probably a little bit more cautious on the asthma side in children, just because our deaths are well, maybe not higher, but we have, if a child dies, it's something serious, right? And if we know that IMT, respiratory muscle training, can dampen off that that awareness or symptom recognition. If they're feeling like they're not as breathless, well, they might not be going to adults and telling them. So I think from that perspective, I'm probably a little bit more cautious when it comes to other things. But often, but again, maybe that research needs to be looked at. I don't tend to use it. I don't use it on every asthmatic, and I appreciate it is used much more in adults. But again, children, when they have a severe asthma attack, they tend to deteriorate much quicker than adults. So I just would probably proceed with caution a little bit more than I would in adults in that aspect.
I think as you've said as well, and you've just touched on it, if one of the concerns is that they think they feel better because their symptoms maybe have slightly improved, but they're not going to tell somebody, then you have to think about the right person in terms of right child in terms of their age.
Yeah.
If they get older, they are more likely to say something, I would have thought, or less.
But not even, like I have 16-year-olds that come to me and they say they're absolutely fine, and we do their lung function, so they're 50%, 30% BDR. So it's really hard. Some of our kids are just not very good at knowing. They're very poor body awareness. They're not doing as much. Our kids aren't pushing themselves as much. They just tend to stop doing things. So I guess, if a child dies, there's a massive inquiry into that. It's a huge investigation, and it's probably something I don't really want to ever have to deal with. So that's probably why unless they're well controlled, it's not something I would routinely do with the asthmatic. Does that on? Yeah.
Yeah. Well, hopefully, somebody's just written, Ali's doing some research in Australia specific to children using IMT, children who are ventilated. So already there's emerging research, at least, and hopefully that will be published so that people can use that. Somebody...
If they're ventilated, that's very different, aren't they? They're in a very safe environment. So I think that's very different than just controlled. IMT on ambulant asthmatic.
Somebody has talked about, I think, trying to make it fun. I don't personally know this groove tube. Don't know if that's something you've heard of. It was just something.
I've heard of groove tube. I don't know if it's a UK thing, but I do think there's some work for POWERbreathe to do.
Well, as you know, we've got the app is out there and continually being developed, which we hope will be really beneficial for the pediatric population.
I haven't heard of groove tube. No, I don't know if it's is that a UK? Whoever put that up?
I'm not sure. Oh no, .nl. So that would be the Netherlands.
Yeah.
The Netherlands.
But yeah, I think there is room for POWERbreathe, with the app now to make it more peds specific. Not that we want kids on screens all the time, but whether we like it or not, they are. So I think you have the app. I think really thinking about how to expand that would be great, because I guess device-wise in the UK, we mostly use POWERbreathe. Well, I certainly do.
Yeah, no, that's the intent, as you say, and we talk about screens. This is obviously diverging slightly from the topic, but it's for so little time a day when you're doing your training. So if it's encouraging them to do it, then we'll try and keep developing. You had a mucus clearance device on one of your slides, and somebody said that they've found incidental improvements with PCF. Is that your experience?
I guess I've never actually monitored, but it's breathing against resistance, isn't it?
Mm-hmm.
So you would assume, again, that there would be improvement in the peak flow.
Yeah, and I mean, it's innovation, isn't it? As you said, I know that there's controversy with is spirometer IMT. You can't necessarily measure the resistance, but even some of the pictures that you showed blowing up balloons, if that's how you start a child, then I guess it gets them into the psyche of what they should be feeling.
Yeah.
So,
and we're starting airway clearance from a super young age, aren't we? We're starting bubble pep in some aspects from the age of 2 years old. We are giving them resistance against their breathing. So I think there's a lot of fear around it, and I think we need to probably take the fear away. And maybe that's just more in the UK. I think we spoke, Sabrina, places like South Africa or Brazil, where we are a little less guideline orientated. We probably do some things that other people would think, oh, that's not okay, but
yeah, I wrote down, I put fear. I was going to ask, what do you think are some of the biggest challenges to initiating IMT? I put, is it fear? And then I was going to write, is it that we are restricted by either guidelines or the lack of guidelines? That was my experience when I worked in healthcare. So I think it's using informed initiative when perhaps there isn't yet a guideline or evidence, but we think it could help somebody. That's probably what I would say.
And at St. George's, we have to, because we have to have guidelines, as you know, in the NHS. So at St. George's, my Band 6 has done a great job at developing a guideline, and thank you, Sabrina and Duncan have looked at it. So if anyone is needing a guideline for the department, happy to be contacted, happy to share, obviously, as long as you reference us, more than happy. We don't want to have to reinvent the wheel every single time. So happy for you to reach out if you are needing that. But yeah, unfortunately, we need lots of guidelines and SOPs and things in the NHS.
And actually, and I'm not, the guideline that Claire's referring to is fantastic. It's incredibly informative, and it covers the concept of IMT. It's specific to a POWERbreathe KH2, but it's really, really useful. And I agree, if it could be useful for other people and you'd be happy to share, I'm sure people would appreciate that. Thank you. Somebody has, one question is, are you wrapping a TheraBand around the chest wall to provide resistance to inspiration for IMT?
I use it a lot for breathing retraining. To give that feedback. Am I doing it specifically as IMT? Probably not. But will it give some resistance to inspiratory muscles? Yes, it will. And obviously it depends on how tight you wrap it. But I certainly use it on a daily basis in clinic, just for breathing retraining.
Okay, interesting.
Yeah.
And then there's one last question, and actually it's about asthma attacks again, which you've sort of alluded to the fact that perhaps it's not something that you would even consider IMT. They've said, how long after an asthma attack would you consider starting respiratory muscle strength training?
Gosh, I've never actually thought of that.
Yeah.
Well, I guess it depends on how frequently they're monitored with spirometry. I think if their spirometry is back to normal, then I think it would be safe to start. So some of our asthmatics have home spirometry, so they could do that test at home. I don't have an exact answer, but I would want them to kind of be back to baseline probably before I restarted it.
Yeah, I think that's fair.
I don't know if there's anything in adults, Sabrina, when it comes to that either, but
Acute asthma attacks, I'd have to delve a little bit further into the research. I'm thinking about recovery from other conditions. Often it's when they're clinically stable and have been assessed by a healthcare professional. So sometimes it's as early as 4 weeks, 4 to 6 weeks. I think it's, again, case by case. Clinically stable is probably the key thing.
yeah.
So, and as you say, there's, especially in the pediatric population, when they've got so many things coming at them and it's really unnerving. It's just, you've got to manage what you're adding into their regime.
Yeah.
I think.
And the thing is, when I start IMT, like, it's really, we've spoken, like, it's always in clinic, it's always with me, I'm always making sure they're safe, and I'm always making sure their breathing pattern is really, really good, and then I would be monitoring that. So, I would say get them back in if they had IMT, tell them to stop with that exacerbation, get them back in and review, because we also know if patients have had a massive asthma attack, the breathing pattern might have changed, so they might have restarted it and might not be doing it sort of, as efficiently or in the bed with good mechanics. So I think it'd be always good to review anyway.
Yeah, it's the basics: breathing technique, choosing an appropriate device, making sure somebody's doing it to get the most benefit out of it, and then reassessing.
Yeah.
Is what I keep coming back to. I think, Claire, in the interest of your time and your voice, thank you so much. We'll leave it there, and thank you everybody for your questions. It was really informative. As I often find with these webinars, and particularly this topic, I think it's food for thought, and I hope that we start seeing lots more really good research coming out. I know we have a lot of research around IMT, but pediatrics is certainly a field that's lacking. So let's see where it takes us. Thank you very much, everyone.
Thank you.
Bye, Claire. Bye.
Bye.